Well, good afternoon. Thank you to FIGO for inviting me to this effort. I'm very happy. Yes, I am from Mexico, but also I am adopted by Canada now. I work for an international organization based in Ottawa. Our mandate is to make efforts to reduce vitamin and mineral deficiencies worldwide, particularly in areas where there is the highest burden. Today, well, I'm presenting a little bit of what is the scenario in Africa, but as I was doing the presentation, I realized that no matter how much information I give, Africa is so rich and with a lot of 54 countries, that my presentation is going to be just general, and I realize that some statements do not apply for particular countries and may apply for others. So please forgive me if I'm not being as accurate as I would like. After the presentation, I would be happy to be more specific and talking that. The outline of this presentation is first covering a little bit of the scenario of vitamin and mineral deficiencies, followed by what is the status in terms of non-communicable diseases. And then we work a lot of international level, and I'm not sure if this area in maternal health is aware that there are global targets for nutrition and for NCDs that countries are already committed to achieve. So to give a little bit of an overview of how Africa is doing, and then summarizing in challenges and resources. Africa is a young continent in the sense that it has around 500 million women. The median age is 20.5 years. That means that most of the women in Africa are women of reproductive age, and very likely just had a baby or are close to have a baby. In Africa, most of the women have their babies before they reach 25 years of age. The scenario is very complex. On the one hand, similar to North America, on the one side, we have a lot of vitamin and mineral deficiencies, and on the other hand, we have NCDs. This is a picture published recently by WHO and shows that Africa has the highest burden, of anemia. 44%, 1 out of 2 women in the continent are anemic. And if you look at the prevalence of women of reproductive age, it's 40%. That means that we need to reach women before pregnancy, because if we deliver the supplements in pregnancy, it may be a little late, particularly because disclosure of pregnancy, it tends to be after the second trimester when anemia is reaching the peak. Unfortunately, there is not much data. If you look, no matter where you look, there is no information on vitamin A, vitamin D, calcium, zinc. The only information that we have is anemia, which in itself reflects multiple vitamin and mineral deficiencies. But it's very difficult to make informed decisions if we don't know exactly what is the deficiency that we are addressing. In terms of birth defects, we don't have the monitoring systems are also very weak. But what we know, for example, is that in average, in Eastern Africa and Western Africa, 40% of women marry at this time, marry at the age of 18, or around 20% by 15 years of age. We know that early marriage is strongly associated with vitamin and mineral deficiencies and with poor nutritional status. And those women, in turn, at 20 years of age, will have 2 or 3 kids, perpetuating a cycle of malnutrition. On the other hand, if we look at this picture and from the non-communicable disease perspective, we know that in Northern Africa and in Southern Africa, obesity is increasing, with some countries in the north part with more than women are more than 30% of women are obese. Not only 50% would be overweight. It would not be extreme to think that. At the same time, we are still making efforts in some countries to address undernutrition. So the scenario, as I said, is very complex. And when we are thinking about policies, like the ones that we are discussing today, it's very difficult to tailor them. And importantly, we have to contextualize them. what is explaining this race in terms of obesity or MAE? I mean, it's a complex issue. But if we look at the physical activity of adolescents, we see that most in the northern area where we have some data, around 90% of the adolescents do not have the minimum level of physical activity, which is 60 minutes per day. So linking the data, young women that are going to get pregnant very soon, that are going to be it's not unlikely to think that obesity is going to increase in the next years, making the problem more difficult, especially if we don't address vitamin and mineral deficiencies as well. So it's clear that we have to do something. I'm not sure how many of you are familiar with these icons. In 2012, member states committed to achieve global targets, reducing stunting, wasting, and overweight in children, but also halving anemia prevalence in women of reproductive age and pregnant women, reducing low birth weight, and improving breastfeeding rates. These three are relevant to women. Breastfeeding, as it was mentioned before, it's important not only for the baby, but also for how weight loss after pregnancy, or for the nutritional status of a woman. At the same time, in 2012, member states also committed themselves to adopt some targets for NCD prevention. So when we are talking about policy level, we are thinking that the nutrition community needs to talk more closely with a community that is addressing NCDs, but also is addressing maternal nutrition. And frequently, I come from the nutrition world, frequently we are not good to get close and get the message throughout all these communities. But we have been, I think, that's successful, as in the case of NCDs. And finally, the Sustainable Development Goals address this key issue. Under goal number 2, zero hunger, there is explicit reference to address nutritional needs of adolescent girls, pregnant, and lactating women. That means that commitment is going to happen. When we were talking about how we can translate these guidelines, it starts from generating the evidence, producing guidelines, but then generating commitment and translated it to professional associations and other communities, so the guidelines can be operationalized and reach actually the people that need the interventions. Well, that's the purpose. You already have the guidelines and the documents on your desk. I'm not going to go through the interventions that have already been mentioned, but the important part, and I think that is worth to highlight, that it has recommendations at policy level for policymakers, at a practitioner level, and also touches on the interventions itself. And usually the guidelines only talk about the interventions. So in that sense, the document is very rich. And I wanted to learn to see how Africa was doing in terms of achieving. So we have commitment, we have global targets, we have recommendations, and somehow we know some of the problems. We have recommendations. How are we doing with reaching those targets? The Global Nutrition Report, the second edition, was launched on the 22nd in New York. And Africa has the best scenario and the worst scenario. Kenya stands out as the only country that is on track of reaching the five targets. And I say 5 because, unfortunately, lower weight, we have so little information. And it's not a nutrition target. It comes from the maternal area. We have so little information that is outside of the Global Nutrition Report. But Kenya is the only one that is on track. Ghana is on track of 4 targets, not anemia, unfortunately. And on the opposite side of the spectrum, we have Mozambique, which is off track in all the targets. That means that investment needs to be spread out through all these countries to make sure that Africa catches up. In summary, if I can say that its challenges, Africa faces many challenges, but those are not unique to Africa. I think that it represents some of the problems that we are seeing everywhere. We need to work harder in translating policy into investment and incentives, and I know that is very high level, but that is what makes brings the resources to associations and to other non-government organizations. We need to work harder in integrating nutrition into other sectors, agriculture and maternal health particularly, and especially within action. We need to shorten the time, and we were talking before that, starting today, we need to shorten the implementation time. We know some options that might work. In data, we have a lot of challenges. It's unconclusive and limited to few nutrients and interventions. Iodine, iron, folic acid. And folic acid, we know that it works, but we know very little in terms of the implementation of fortification or supplementation in early pregnancy. As I said, we don't know the level of implementation. We don't know the market share in terms of the private sector and public sector. So if we want to strengthen the systems, we need to know a little bit more about that. There are limited evaluations in terms of interventions. Yes, we have some interventions at clinical level, and we have been successful in proof what can work. But at population level, there's as many answers as approaches, and we don't know exactly what works. And in terms of delivery, I always say that here we are focused on women, but men also count. And we're talking about women's nutrition, but in many settings, men are the decision makers, and they need to be part of the solution at different levels. We need to generate more information on which other nutrients should be delivered. Multiple micronutrient supplements seems as a reasonable option, but is that the answer that some countries are looking at? Well, we need to know a little bit more. And personally, I think we need to make more effort in terms of the task shifting, training better community health workers to make sure that these interventions are reaching those that are hard to reach. These are the resources for those who are interested in this type of information. The WHO Electronic Library of Nutrition Actions provides a lot of guidelines, best practices, links to documents. Likewise, with the WHO Reproductive Health Library, the Global Nutrition Report, if you want to read 210 pages on how is the global nutrition status, please do so. It has really interesting information. And there is globally scaling up a nutrition movement that provides a lot of information at country level. So we really are not starting from zero. We can build on some successful stories and make sure that nutrition can be scaled up. Thank you.